Well, good evening, everyone. Before this evening's program begins, we wish to recognize the recipients of the Blue Cross and Blue Shield of Illinois American Dream Scholarships. These 6 first-year students representing each of our academic colleges, as well as the Schaumburg campus, each will receive a $5,000 scholarship, made possible through the generosity of Blue Cross and Blue Shield of Illinois. Now, I will invite Clarita Santos, Executive Director of Corporate and Civic Partnership at Blue Cross and Blue Shield of Illinois, to join me as we present the award. Clarita, if you want to come up here, please. So if you want to be here, yeah, just hand them the certificate. So students, as I call your name, please make your way to the stage. Cesar Correa, Leslie Puerto. Is Leslie here? Okay. All right. You can come up here, and Cesar, you stay right there. We're going to take pictures together. Okay. And Henry Salinas. All right, I'm going to take a picture with all of you and my mask. All right, wait, don't go anywhere. Congratulations again. Okay. Now, I'm going to go down, and then you will be in charge.
Thank you. Good evening, everyone. Welcome to the Public Health and Healthcare in a Post-Pandemic World panel discussion. We have many meaningful topics to cover with our highly distinguished panel of experts. But before we begin, I would like to thank Maurice Smith, President and CEO of Healthcare Service Corporation and Board Chair of Roosevelt University, who has sponsored the American Dream Reconsidered Conference from the beginning and was actually part of its inception. I would also like to thank Roosevelt University leadership, President Ali Malekzadeh, Professor Stuart Warner, Dr. Michael Ford, and Nicole Barron for all their leadership to make this conference happen. Now, let's meet our impressive thought leaders for the panel discussion. In the middle, we have Dr. Ngozi Ezike. Hello. Dr. Ngozi Ezike is Director of the Illinois Department of Public Health. Dr. Ezike is a board-certified internist and pediatrician who previously worked for the Cook County Department of Public Health, where she served for more than 15 years. She was also medical director at the Cook County Juvenile Temporary Detention Center. Prior to joining the Cook County Department of Public Health, Dr. Ezike served as the Austin Health Center medical director, where she actively engaged with the community on health initiatives. She has delivered inpatient care at Stroger Hospital, both primary and preventative care in community and school-based clinics. Our next panelist is Dr. Carlos Del Rio. Dr. Carlos Del Rio is a distinguished professor of medicine at Emory University School of Medicine and a professor of global health and epidemiology at Emory's Rollins School of Public Health. He serves as the Executive Associate Dean of Emory University School of Medicine at Grady Health System and is the co-director and principal investigator at the Emory Center for AIDS Research. Del Rio is the International Secretary of the National Academy of Medicine and chair of PEPFAR Scientific Advisory Board and a member of the UN AIDS Scientific and Technical Advisory Committee. Our moderator this evening is Dr. Kelly Wentz-Hunter. Dean Kelly Wentz-Hunter is co-dean of the College of Science, Health, Pharmacy, and professor of biology. She earned a BS in biology from the University of St. Francis and her PhD from Rosalind Franklin University of Medicine and Science in Pharmacology and Molecular Biology. Before joining the faculty of Roosevelt University in 2006, she completed postdoctoral research at the Lions of Illinois Eye Research Institute at the University of Illinois. At Roosevelt, she has been involved in developing programs in allied health with Northwestern Medicine, including diagnostic medical sonography, radiography, and histotechnology, as well as the highly successful MA in biomedical sciences. As a first-generation college student herself, she understands the challenges of many Roosevelt students and is dedicated to providing support for their success. She currently is a program director to providing support through the Howard Hughes Medical Institute Inclusive Excellence in Sciences grant, supporting increased retention and graduation of people excluded because of ethnicity and race in the sciences. And she also serves as co-principal investigator on the Department of Education Title III Hispanic Serving Institution STEM grant, Roosevelt University Learning and Engagement for STEM Success. Please join me in welcoming our distinguished speakers.
All right, thank you very much for that great introduction. And I'm really pleased to be on stage with these amazing researchers and physicians today. And so I thought maybe we could just start by you describing a little bit what your role has been and your day-to-day as part of this pandemic. Just short. We start with a short little answer.
You're going to start at 6 in the morning? What time?
No, I mean, of course we do. The days are filled. No 2 days are exactly the same. Of course, we are probably like everyone else, a lot of meetings, Zoom meetings, WebEx, whatever the platform, a lot of check-ins. As the director of IDPH, of course, there are over 1,300 employees organizing 200 different programs that are, have been established to keep Illinoisans healthy. So those 200 programs continue. That does not include the 201st program, which has become the COVID program, which of course didn't exist 2 years ago. So lots of check-ins around COVID, lots of check-ins around the other programs, lots of check-ins with the governor's office to let him know what the team is doing with regards to COVID and these other programs. And then, lots of appearances and interviews and trying to put information out on social media, keeping up. Right now, we're very involved with trying to, last night, Dr. Walensky of the CDC signed off so kids 5 to 11 can get vaccines. So we really just want to make sure that there's a smooth rollout of that throughout the state for everyone who wants that vaccine to get it as quickly as possible, and for those who think they don't want it yet to get closer to wanting to get it.
So I would say, I was all my life I've been an HIV researcher, and it was only in the past 20 months or so that I've done something different, which is COVID. So none of us was a COVID person, and therefore we all had to become experts on the go. And I think that's something that people frequently forget, that this was a novel disease, and nobody was an expert from day one, and nobody's still an expert. We're all about the same level, trying to understand and trying to learn the science. I think that, my role has been at different levels. I have done, my primary role, because of my role as a person in charge of the Emory Medical Services over at Grady, my primary role has been to ensure the safety of our healthcare workers. So one of my primary roles was ensuring that there was enough PPE and with enough information, enough education, enough training, availability of testing, availability, all those different things that people needed, vaccines, you name it. It has also been ensuring, the care of our patients with COVID during this time. Again, care has been transformed in ways that are very hard for people to understand outside the healthcare system. The fact that most hospitals closed the ability of visitors, that meant that people would be in the ICU by themselves with nobody to be with. People died alone. People were not allowed to come and visit their dead relatives. A lot of very different things. I mean, this is not normal. We've never seen this, right? I tell people that in the early years of the HIV epidemic, we didn't have treatments, but we couldn't give people a hug and give a hand and let their family members be there. This is very different. You can't do that. Even when you can give people a hug and a hand, you will do it with PPE on. So I was trying to figure out how do we get, iPads into patients' rooms and other ways so they can communicate to their families and they can, I've seen plenty of people say goodbye to their loved ones through an iPad. And it's not, it's been very different to try to implement all that. I've always been involved. I'm still a clinician, so I still see patients. I've been involved in clinical trials, both the clinical trials that led to the approval of remdesivir and also the clinical trials of the Moderna and the Novavax vaccine. I'm one of the investigators. But the other things I've done is I've been, very active in the media, both in television and in press of other types. Very active in social media. I mean, this is the first pandemic of social media, and that has been very different, right? And I think all of us have learned the power of social media, both to inform and to disinform. And it's a yin and the yang, right? The good and the bad of social media. And then finally, I think the other role that I've had, which consumes a lot of my time, is advising people. And I'm talking about, all the way from the mayor of Atlanta to Delta Airlines, to the Atlanta Symphony, to the cruise industry, you name it. The number of companies that say, tell us what we need to do is huge. And the great majority of them have no idea. Nobody had thought about this as being something that was going to happen to their business. And I think that's something that has also been very, I would say, interesting to me and transformational to me, is also get to learn about other businesses and other industries that I would never have. I mean, I know more about airline, air circulation that I've ever cared to learn. But I know it, right? Because I had to learn it. I had to understand it in order to be able to give advice. And so therefore, it's been also a lot of time of learning things that I never had zero interest in, but I had to learn in order to be able to do the right things during this pandemic.
So you bring up a great point, is that, no one knew anything about COVID. This is a pandemic. So when was your aha moment, or when did you realize that you were dealing with something that was going to become a pandemic, or that this was really serious? And at that time, what did you think was going to be the worst case scenario?
It's interesting to try to rewind and unknow what you know now, right? But I remember New Year's New Year's Day or New Year's Eve of 19 going into 20. I was overseas. I was in West Africa for the holidays, and I saw some reports about something happening in China, but didn't think anything of it. But it was only maybe 2 weeks later that we were on calls with the CDC talking about the possible eventuality of having to quarantine people coming from flights from certain parts of the world, and trying to mobilize, trying to identify, the airports from which flights from Wuhan would be directed to. And they were thinking of putting O'Hare on the list. And so O'Hare's in Illinois. So that's in my purview, and figuring out what the plans would be for those individuals, what would be the protocols. And so it was just kind of theoretical. We initially weren't one of the airports, but just, having those meetings something's brewing, something's brewing. And it actually wasn't long after that, because Illinois actually had the second case in the country. The first case was in Seattle, was in Washington. I don't know if it's Seattle proper, but the second was January 24th is when we confirmed, although we had been treating that patient for over a week, waiting for the results to come from the CDC. So we knew early in January that, first case, second case was the spouse of that first case, and then it just kind of trickled on from there to the 1.7 million cases.
I think for a couple of things, as you said, for me, it was first hearing about these cases in Wuhan, China. I must say that I had to rapidly pull a map and say, where is Wuhan? Because I had no idea. And I called one of my colleagues who actually has collaborated with people in Wuhan. And I said, tell me all about the city. And this person said something very pertinent. He said, think about Wuhan as the Chicago of China. It is a city, it's a city in the center of the country, which is very important. It's an industrial and economic hub for the country. And that was a very important image for me. I said, well, if Chicago is to the US, what Wuhan is to China. And that was a very important, idea that I had. I realized that all of a sudden, as you said, where are flights to? And I discovered very quickly that there were direct flights to many cities in the US. And because of the importance of Wuhan. And therefore that likely cases were already here. And that we were, sort of the cat was out of the bag, basically, before even we realized. But I would say that at that point in time, I still was hoping that this was going to be a fairly contained or small. I was thinking more SARS. If you remember 2003, SARS was big, but there were 9,000 people infected and about 700 deaths globally. I mean, I was thinking it was going to be somebody like SARS. I mean, we saw cases in the US and in Canada and other places. So I was thinking something like that. I wasn't thinking we are where we are. It wasn't really until early March when I went to a meeting. I went to have a meeting with the Assistant Secretary of Health, Admiral Brent Gerard, to talk about opioids and infectious disease. I had just finished a report from the National Academy of Medicine talking about the integration of opioid use disorder care and infectious disease care. And I was going to debrief him on that and tell him what the recommendations we were coming out of in that committee were. And so I had a meeting in DC. So I flew up to DC, and as I was going to his office, he says, well, we need to cancel the meeting because I'd just been called to the White House for an emergency meeting to talk about the situation with COVID. And he said, why don't you wait here for me to come back and we'll talk afterwards. So I stayed in his office, debrief his staff. And when he came back, he basically told me that what they had learned in the White House. And he said, this is going to be serious. This is going to be big. This is something that is going to require immediate national attention. And shortly thereafter, I think even the next day, is when the president, appointed the vice president as the COVID task force, and all the things started happening. And even though there was being sort of downplayed from the White House, I had heard how the entire internal discussion was that this was going to be big. But then but even when we thought big, all of us were thinking 60, 100,000 dead in this country at most. I mean, I think back then, if you had said to me there are going to be 700,000 plus deaths in this country and 5 million plus globally, I mean, I think if anybody had said that in the news, everybody would have laughed. They would have said there's absolutely no way that's going to happen. So we were all thinking 60 to 100,000 at most people dead in this country from this pandemic. So I think also even though we realized it, I don't think any of us had a remotely an idea of how severe and how significant this was. I think if we had learned, if we knew back then what we know now about how rapidly this virus spreads, how difficult it is to control, how severe it could be, and how rapidly it was going to spread through nursing homes, through many other places, I think we would have acted very differently from the beginning. And again, it goes back to one of the important lessons I think out of this pandemic out of any pandemic, but this one in particular, is you make decisions based on what you know at the moment, and you kind of wish you knew tomorrow, what you knew today, what you're going to learn tomorrow. Because the reality is, at the beginning, we said there's no need for masks. And then we said, well, there is. And then we said, this is transmitted through surfaces. And then it turns out it wasn't, it was airborne. And I think all those things played out in the media, played out in live. I think one of the bad things about this pandemic is people have seen science develop in real life, right? And that making and seeing how the sausage is made has been really bad, because the reality is people think science is something like you open a box and you pull it out and this is science, right? It's already done, right? It's not like making a cake, right? Everybody, and here people saw the beginning from buying the ingredients to making the cake and burning the cake, and people say, well, then these people don't know how to cook. And that has been part of the problem, is that science has lost credibility and public health has lost credibility because we seem to not know what we are doing. And the reality is we know what you're doing today, but maybe not tomorrow.
I mean, the truth is science has been in a box because, they think of diseases that were taken care of. We know measles, we've had hundreds of years of experience, so we can tell you everything about, when you'll be infectious, what the symptoms look like, it when you see it. And so many diseases, it's in the books, so you can read, you can go to Dr. Google, so you can find out everything. And so when you have something that you can't, we are the science that people are going to read about 20, 50 years from now, and people are not comfortable or just don't understand that.
But do you think that is maybe a failure of our educational system, that people don't understand what the scientific method is? I mean, as a scientist, right? So we know that, we have to make observations, and then we, do experiments, and we get results and we analyze them, and that we're always changing our analysis and our conclusions based on the data we get. But yet, like you mentioned, as it plays out in real time, people are like, oh, you're wrong, you don't know what you're doing. But that's science.
Where have you been my whole pandemic experience?
But I mean, how do we as scientists and physicians, how do we get that message across to people to understand that this is how it works, that it's not that we don't know what we're doing, but that this is how science works? How do we get that message out so that they trust us and that they trust the process?
I don't think you never. I mean, you can teach people that, but the reality is, people are never going to trust that, because if you imagine yourself, you're in a difficult situation. When you look at the person in charge, you want that person to tell you that they know what they're doing. I mean, I don't think you want somebody, if you're having a problem in an airplane, you don't want the captain to say, well, I could do this or I could do that, I'm not sure. You would not be very happy. You need somebody to reassure you, and you need somebody to say, look, trust me, we know what we're doing. And I think the reality is that that's what people are looking for. So no matter how much you educate them, in a crisis situation, people want reassurance. And the problem here is that it's very difficult to give people reassurance. I think what we've not done very well necessarily is telling people what we don't know. And I think it's been very important to tell people what we don't know, but we're still researching. And when we know, we'll come back and tell you. But I do think that the other thing that we've lost, and where I think we can make a difference, is public health has been incredibly undervalued in our country for years and years. And it's been incredibly underfunded. I mean, people don't realize that over the last, after 9/11, when there was a big peak on people recruited and brought into public health, et cetera, once that died down, we've seen in the past 10 years, 15 years, over 50,000 jobs in public health disappear. And my former boss, Dr. Jim Kern, who was one of the pioneers of HIV at CDC, always says that when public health is working, nothing happens. Everything is quiet, right? Yeah. But it's only when things go wrong that people realize, oh, where's public health? And what happened is exactly that. We underfunded public health because we said we don't need them anymore. We're fine, right? And all of a sudden there's a crisis and we're like, where are these people? And the reality is that we have, as a country, undervalued and underfunded public health. And if there's something we can teach people, rather than teaching science, and I have nothing against teaching science, I think we need to teach people the importance of public health. And I think if you look at what people think, if you go out to the street and ask people what is public health, the great majority of people have no idea. When I've done that, the answer you get is healthcare for the poor. That's what's public health. People don't understand what public health is. People don't understand what the role of health departments are. And until we change that, I don't think we're going to get the kind of support for public health that I think we needed in this pandemic in order to prevent a lot of the bad things that have happened.
I think he touches on a great point. I know one of the first things when I came into the role that I said we needed to do was to create our own, just how schools will have like our own brag video. Like we'd have a short version and a long version where we would get a team to go and videotape different members. We have offices all throughout the state, not just the Chicago and Springfield, but we've got like 10 different offices spread out through this large state, and that we would interview people and talk about the different things that people do, and that we would show like some of the sites that I don't think people realize that, how they figure out whether it's safe to go into the beach, that when they go to the hotel pool to make sure that that's not going to result in a gift that keeps on giving, that it's because, there are people who are regulating and monitoring so many things, whether it's the lakeside water, whether it's pools, from that to, it's not just about, food outbreaks and salmonella and food, recalls. And so we wanted to create this video that we would take on the road and really as part of the initiative, because I wanted to work on building up the public health workforce and recruit new people from different backgrounds, go into middle schools and talk about what public health and generate that interest. Haven't been able to do that yet, but I think the time is even more ripe now to make sure that people completely get it, so that when it comes to these important decisions of where we're going to put our money, you won't be like, no, public health, no. They're like, no, public health, yes. So that's a big shift that we're hoping to see. That I think even though there's, the public health officials in this state, the local health departments have gone through a very tough time. I'm telling you that our local health departments, and we have 97 different health departments that kind of work in their respective counties for the 102 counties. And I have public health administrators that have had their homes vandalized. I have people whose kids have been assaulted because they were the kid of the public health administrator. I've had nooses put outside of people's homes because football games were canceled because everybody had to be put in quarantine. So this is a rough time, but I'm trusting that history will be kind. And I don't know how far we have to get removed from all of the vitriol and the passion for history to advance, for us to look back and say, oh no, we definitely did a disservice to the people who were trying to actually help us, and so that we can take advantage of that to really, uplift and restore the image and reputation, and also hopefully solidify dollars that will be recurrent to save the important work that needs to be done.
That, it's kind of sad to hear you talk about, that some of the people that work in public health are being attacked for just doing their jobs, right? And, public health has always been political because it's a government institution, right? But now it seems like it's becoming partisan, right? So we're starting to see the divides that we see in the country. So why do you think it's changed from just being political because it's a government institution to now being partisan and starting to see the same divisions that we're seeing in our country?
Yeah. I think we know. I think we have some ideas.
Right. Share those ideas.
But I think what happened is, as you say, public health has always been political, right? I mean, public health is political, but public health had never been partisan. And I think about, for example, HIV. I mean, the Ryan White Care Act, PEPFAR, it's always had bipartisan support. It's always been something that people at both sides of the aisle have supported. I think what has happened right now is not necessarily that public health has become partisan, but we have politicized what's technical. I mean, the recommendation to wear a mask is a technical recommendation. It's not a political recommendation. And we have made something technical, like a vaccine, political. So it's not necessarily public health that has become political or partisan, is that we made public health interventions become partisan and political. So, if I go into a room and I want to see, who's Democrat versus who's Republican, I just see who's masked and who's not masked. I mean, it doesn't make any sense that something that is clearly technical has become political. And I think getting away from that is not going to be easy. It's really going to require a very, very different approach, because it has become no different than wearing a pin, or no different than wearing a Confederate flag or whatever. It's been a symbol of something, right? There's a symbolism attached to wearing a mask in this day and age that I think dramatically, would have been so easy if the president had said, oh, Dr. Fauci says I need to wear a mask, I'll put a mask on. I don't necessarily like it, but I'm following the recommendation. As opposed to the president standing and saying, well, the recommendation is to wear a mask, but I'm not going to use one. So basically saying, if you're with me, you shouldn't use one. I mean, I think there's different ways in which the message could have been communicated that I think would have been very different. But the point that we're at right now, I think it's going to be very hard to change that because, all you need to do is just turn on the TV or turn social media and see what the message continues to be, right? I mean, just tell me where the vaccine misinformation is being transmitted more frequently. And until that changes, I don't think we're going to see a dramatic change. And I think that makes it incredibly hard for people in public health to do their job because, who would have guessed that you would be, your home be vandalized because you were a public health expert?
Yeah. No, I mean, to give another point as well is that with human behavior, change is hard, right? And so I remember looking back, trying to say in fact, I gave a commencement address 2 years ago. So that was 2019, where I was talking about how this is pre-COVID, this is May of 2019, talking about public health has one of the hardest tasks in that it is convincing people to change their behaviors. And that is not something that people do readily, whether you're trying to get somebody to stop smoking, whether you're trying to get somebody to increase their activity, whether you're trying to get people to use condoms. These behavior changes are never taken lightly. Even if you think about, seat belts, people were revolting that they should not have their freedoms taken away to put their seatbelt on. That debate did happen. So it's not completely different from what we've seen now in terms of people being told something new they have to do and them just saying, oh no, I don't want to, you can't tell me what to do. We see that with everything, don't smoke inside a building. No, you can't tell me where to, right? All of that happens. So there are some similarities. And then if you add the politicization on top of it, it's bubbled up to be a mess. But, part of it is just behavior change is hard. Human beings don't want to change. We want the status quo. And so that is part of it as well.
I would be interested to hear your own interactions with Governor Pritzker, and also, so Illinois is kind of a dichotomy, right? So we have our metropolitan area in Chicago, and we have a lot of rural areas that, if you're in Chicago, you see a lot of people wearing masks. If you're in more rural areas, you don't see that as much. So can you maybe just talk a little bit of how you have kind of dealt with that dichotomy and gotten your message across to be effective in this state? Because I think you have been very effective in this state.
You're coming from Northern Illinois.
Yeah, I'm in Northern Illinois, but I have family that's not in Northern Illinois, so I know what's happening in rural.
No, it's such an amazing state because it's so diverse. We really have this one flagship world-class city, but the rest of the state is like majority rural, and which I don't think people understand that. And so, as I travel all around the state, you have places where it's like, oh my gosh, look at the adoption of the mask, primarily here in Chicago. But, I remember going down to Southern Illinois, like I think Jackson County, giving commencement addresses this year, and my kids, so we drove all the way down from Chicagoland to Southern Illinois. And so my kids were like, nobody wears a mask here. Like, in a restaurant, the waitress is coming up coughing and asking for our order. And my kids were like, oh my goodness. And just to have us wearing a mask, they're like, oh, you guys aren't from around here, are you? So it was very different. And unfortunately, that manifested in the vaccination rates. Like we've broken up the state into these regions, and like the southern region has absolutely the lowest vaccination rates for seniors, for 18 to 64, for 12 to 7, for every group, it has the lowest rate of vaccination across the board. And I say that's why we saw this significant problem when the Delta surge just hit. I mean, we were spending all of our attention. I was in Southern Illinois quite frequently trying to work with the hospitals. We were actually calling the federal VAs and saying, look, we need to move some of our patients, non-COVID or COVID, to your VA. They're not veterans, but we have not a single bed left in the entire southern region. We have no ICU beds. There's no place to put a patient. We were working with other partners in other parts of the state, airlifting. Sometimes patients were going out of the state to, Kentucky, wherever we could find. So it definitely has had the consequence of not being vaccinated, of maybe not wearing the mask as much. And so we have had to accommodate that. And one of the accommodations that we did, at least with regards to COVID, is, okay, one size does not fit all. I can talk about vaccines till I'm blue in the face. There are people who are not going to get this vaccine. You did the vaccinate, or you have to test every week. People would say, I will test every hour. I'm not taking that vaccine. Okay, so plan B, okay? And so plan B was like, okay, let's use monoclonal antibodies. So if you identify yourself as being COVID positive, let's get you this treatment that can prevent you from ending up in the hospital or worse. And for some reason, this same emergency use authorized experimental drug was like, yeah, I'll take that. I'll take the monoclonal antibody. And so we were, shipping, making sure many doses of monoclonal antibody were going to partners in Southern Illinois, because people would take that. So much for an ounce of prevention is worth a pound of cure. It was like, no, I'm not going to prevent, but if I get it, okay, I might be amenable to this treatment. But we do need to have multiple things in our arsenal, so to speak, because one message is not going to resonate with all, and you can't. I kept preaching to local health departments and to my team that we have to have compassion for the unvaccinated. Like, people were getting like, oh, they caused this, they did this, it's their fault, we shouldn't pay for the medical. Like, you have to have compassion for the unvaccinated. At some point, I was thinking, well, if people have been a victim of misinformation, their beliefs are as strongly held as the ones that I hold. And so because they were inundated and just bathing in this information that they think is true, that's how they've made their decisions. And so you have to still make a commitment that we're saving as many lives as we can. And, maybe vaccination is not your choice right now. So at least here are some other options. And so I'm very grateful for the monoclonal antibodies. We're looking forward to some of the antiviral medicines that might be coming through soon that might give another option for people to stay healthy, protect our healthcare resource, and help us hopefully manage this.
I think it's interesting when you talk about like not vilifying the people that are not vaccinated, right? I think it also kind of brings me a little bit to your previous work, Dr. Del Rio, because you've worked in AIDS and HIV, right? And a lot of times we, especially in the beginning in the early 80s, we tried to vilify people who had HIV or AIDS. So maybe can you talk a little bit about maybe some similarities between that epidemic and this pandemic?
There are a lot of similarities. And as I said, I think about the early years of HIV, starting, post medical school, starting residency in the 1980s. I mean, there was, the fear, the enormous fear that somebody had HIV, and you would get it, questions that came, oh, somebody with HIV just went to the bathroom before me, and could I get better? I mean, all sorts of different concerns, a lot of stigma. I mean, you need to remember initially we talk about the 4 H's of HIV, it was, homosexuals and heroin users and Haitians. And, again, it's this whole stigmatizing has been, again, it's something that humans tend to do, right? You tend to blame somebody. You tend to, and I think that one thing we've learned in HIV is how bad stigma is, and how stigma really is one of the major barriers of diagnosis, care, prevention. HIV started with, wealthy or middle-class white gay men who, in this country, who travel and, got infected and went partying, right? But who has HIV today? It's primarily African-American, Hispanic, minorities, poor people, right? So epidemics tend to also eventually settle in the poor, right? And what in COVID, we saw exactly the same thing. Who were the first cases in this country? Were travelers who went to other places, or people that went in cruise ships? And then who is the most affected population in our country? is minorities, is Black, is the poor. So again, that disparity that everybody's is, oh my God, this enormous disparity in COVID. Well, COVID is not the only disease of disparities. It's almost every other epidemic is a disease of disparities. Almost every other disease, obesity, diabetes, you name it, right? So I think we need to realize that health disparities are at the core of health inequities, are at the core of a lot of our problems in health that we have in our country, and therefore, and COVID is no exception, and therefore the importance of sort of health equity, when people talk about what can we do to improve health in our country, it really is about equity. It really is about changing and it's not about just healthcare access. It's about really social determinants of health. It's about where you live. It's about, how you live, what you eat, et cetera, what work you have, what income you have. That really is what determines. We're very excited, and physicians always keep on talking about genetic medicine, and I'll be able to tell by your genes, what diseases you're going to have. Well, I'm able to tell by your zip code what diseases you're going to have. It's your zip code that determines really the kind of illness and the life expectancy you're going to have. I mean, I live in Atlanta, and I'm sure the same thing happens here in Chicago. There's in the same county, in Fulton County, there's a very wealthy neighborhood called Buckhead, and there's a very poor neighborhood called Bankhead. They're 5 miles apart. The life expectancy of a man in those places is 7 years apart. I mean, we're not talking about two different countries. We're talking about the same county 5 miles apart, right? But when you look at the social determinants of health, that's what's driving that 7-year difference in life expectancy. So I think it really should make us think about really what do we want as a country going forward, and how are we willing to continue living in a situation of health inequities, or are we in health disparities, or are we more into justice and I think HIV, clearly one of the things that HIV has done is that it has had health access and health equity at the center. And I would say again, the Ryan White Care Act is an enormous example of something that has provided health equity. PEPFAR, I mean, HIV is the only disease for which the number of people on treatment is exactly correlates with the epidemic. The more people on treatment are in Africa, because that's where the epidemic is concentrated. There's no other disease for what that happens. I mean, just to give you an example, Durban, South Africa has more people on antiretroviral therapy for HIV than the entire United States. But that's good, because that's where the disease is. So again, global health equity is something that HIV has brought into the forefront and has made it. Today I was in a PEPFAR meeting, and PEPFAR has always made health equity at the core value. And I think we need to make sure that we make health equity a core value in what we do, anything in health. So I would say, let's learn from HIV the good lessons and what the things we can do going forward to prevent us from making the same mistakes. I would say honestly that, for example, this phrase that became very common, this is an epidemic of the unvaccinated. Well, yes, COVID has always been an epidemic of the unvaccinated. Before we had vaccines, this was an epidemic of the unvaccinated, right? I mean, so it doesn't help to say that, because the reality is that if it's something that is just stigmatizing the unvaccinated, and it's creating even, I think, a higher barrier for those people to seek a vaccine. So how do we frame our message in order to prevent unintended consequences, like discrimination? Like, I've seen healthcare workers say, I'm not going to take care of this person because they are unvaccinated. And you're like, excuse me, but what are you talking about, right? I mean, it's no different than a surgeon saying years ago, I'm not going to operate on this person because they got HIV. I'm sorry, but that's not that's not who we are. So we have to be careful that we don't produce those same mistakes. I think the other similarity with HIV has been the proliferation of pseudo treatments, right? And in the I mean, again, people don't remember this, but in the early years of HIV, there was Suramin, there were herbs. Look about the things that Rock Hudson took. I mean, you can read and see all sorts of things that he took, except that, and then eventually we had highly active antiretroviral therapy in 1996, and things changed. But also, what HIV took 10 years or 20 years, and COVID takes 10 minutes, right? And that's also part of the problem, is that medications and other things have been developed so quickly that we don't tend to remember that looking for herbs and looking for alternative therapies is part of human behavior. It's part of what we see people do in a desperate circumstance. And I think we also need to understand it as such. That yes, Aaron Rodgers said that he was taking, herbs and vitamins to prop up his immune system. Well, I'm sure it works, but the vaccine works a lot better.
Or use them both.
Yeah, use both.
I take vitamins and herbs. Yeah.
Exactly. I want to change gears a little bit because I know before we were talking a little bit about a lot of people didn't know about public health and what they did before. And one thing we've all found out is that there was a pandemic plan or a pandemic handbook. But I like maybe you both to speak a little bit about like who's in charge of the pandemic plan or this handbook. How does it get activated and disseminated? And kind of what is this pandemic plan or handbook that's out there for public health?
So interestingly, there's a whole office, the Office of Preparedness and Response, that's dedicated to just being ready for whatever kind of public health emergency. And we, after 9/11, a lot of money was invested in these kinds of measures for trying to get ahead of things or planning before the actual, eventuality of some kind of emergency. So in our operation, in our OPR, Office of Preparedness and Response, it involves like exercises and drills. And I think that was 2019. In 2019, it was in 2019, in the summer of 2019, we actually did a drill. And it was a full-scale drill involving the Illinois Department of Public Health, other state agencies, even other states were involved, and the feds were involved with this drill. And so this is it's not a real event. It's not happening, but everything has been laid out. We are going to walk through everything like this is a drill that we are going to act all this out. And the drill scenario was that there was a flu virus out of China that came, to the States and was ravaging the country. And so it was talking about, okay, how will we get the education out? How will we get, this is the difference that, how will we get antivirals, which are in our, strategic national stockpile? How will we get the antivirals? How will we get vaccines? Do we have, how many, needles and syringes? How much of all this stuff would we need? So that drill, it was like a week-long drill with all these players. The difference was that there wasn't an antiviral or a vaccine already available that we could use to implement that plan. But so that did have a lot of similarities to what we ended up encountering less than a year later. And so, these ideas of having stockpiles of PPE, like that plan is already in place. Thinking about how, if you have to disseminate something quickly, i.e. vaccines that come on board and get it to all parts of the state quickly, how do you do that? We already had regional hospitals that would be the quote hub where things would go to these strategically identified regional hospitals, and then things, this hub and spoke model, things would get moved out to all parts of the state from those regional hubs. So that's part of, the things that we have, that we do in preparedness and response, and that were part of, this emergency like pandemic planning, that are exercises that go on all the time with that office to be ready to implement the strategies that we've had to implement over the last 2 years.
I think Muhammad Ali was the one that said, we all have a plan until you get punched in the face, right? Plans are great until the virus hits you, right? And I think, as you said, it was George W. Bush after 9/11 that there was a desire. The Office of Pandemic Preparedness was started, and there was the Assistant Secretary for Pandemic Preparedness and Response Office, and then pandemic plans were created. I think one thing that happened is that, again, we were all wrong. Everybody said the next pandemic is going to be influenza. And in fact, it was 2009. We had a pandemic of influenza. But so everybody was expecting a flu virus. Nobody was expecting a coronavirus. And that had implications, because if you look at the pandemic preparedness plans, because of influenza, in influenza, you don't need N95 masks. The pandemic preparedness plans did not have N95 masks as part of the requirement. So therefore, there's not a national stockpile of N95 masks. Had there been the thought that this virus could be easily transmissible, like COVID, and N95 masks would be required, there would have been a national stockpile with N95 masks. That had consequences, because the mask producers dramatically shifted from producing N95 masks for healthcare to N95 masks for construction and for other businesses, because there was no need to have a stockpile of N95 masks. And again, that was a big mistake, right? We should have thought, well, how about if it's not a virus like influenza, if it's a virus more like SARS? We should have thought about that, but nobody did. And therefore, everybody was focused on an influenza plan. And that was also part of the problem. We pretended once things happened, everybody looked at an influenza plan instead of thinking about what needs to be different. So I think one thing was clearly that the plan we had was for the wrong pathogen. And that created some difficulties. I think the second issue is nowhere in the plan does it say this thing is going to become political. And in all those exercises, you never had an exercise
You
saying—
didn't read the footnotes.
Yeah. You never had an exercise saying, what happens if the president all of a sudden says that this is not real? What do we do then, right? Nobody had that in the plans. And nobody had it. So, and you need to think that, what do we need to do, right? And then the third thing is nobody put in the plans, what are we going to do to combat misinformation? If you read any of those plans, misinformation word never appears. So I think those were three major flaws of the plans that when we implemented it, we said everything is fine, until all of a sudden everything was not fine, because those things were not part of the plans. Then the other thing is, I think, and I would love to hear your opinion about this, is that, you know, in our country, by the Constitution, public health is run at the state level. But when you're talking about pandemic, when you're talking about something like this, you really need to have some sort of federal level. And there's nothing in the Constitution that allows the federalization. And what we have in this country is 50 different plans and 50 different states doing 50 different things. And the reality is, think about going to fight a war. And you say, well, you know, we're going to fight in Korea, but, you know, each state is going to send their own troops, and each state is responsible to recruit their own soldiers and buying their own rifles and getting their own ammunition. And this is what happened, right? The federal government said, well, states are responsible for buying their ventilators, and states are responsible. So you started, even right now, with nurses. I mean, nurses get outbidded by different states because there's not a national plan. It's all run at a state level, and therefore states are competing against each other in ways that I think creates really a very poorly executed response. And then the last thing I would say about the plan is that there was not a thought about— well, I think it wasn't in the plan, but I would tell you that after 2009, when the flu pandemic happened, and, you know, by the time the vaccine was ready, the pandemic had pretty much gone away, right? There was a lot of work to develop a vaccine, and by the time the vaccine was available, and I remember talking to Dr. Fauci, and he said to me that he said, the president said to me, how come you didn't have a vaccine on time? And he said, I will never have a president again say to me, how come you don't have a vaccine on time? And he made a lot of investment into— the NIH made a lot of investment into the Vaccine Research Center at the NIH, where a lot of the work in the mRNA vaccines and in coronavirus was done. I mean, when you talk to, for example, Kissy Corbett went to NIH because she was studying MERS. That was the virus she was studying. And she was developing a vaccine for MERS and working on mRNAs for MERS. And that's how— so all that investment in vaccines, and I think we did a bad job of communicating to the public that the NIH Vaccine Research Center was actually in the process, was actually part of the pandemic preparedness, and was really making sure that we were going to have the technology necessary to develop a vaccine on time. So when people say, well, this was developed too quickly, well, it was because there were, you know, since 2009, they've been working on making sure that we had a vaccine really fast in case of a pandemic. And all that work that background started back in 2009. And I think we didn't do a good job in incorporating the work of the basic scientists at the Vaccine Research Center as a strategic component of the National Pandemic Preparedness Plan, because that's what it was. But we never communicated that to Congress, to anybody, right? So all of a sudden, when the mRNA vaccine appeared out of nowhere, people say, well, this is too new. Well, it wasn't too new. There was a lot of research behind it, but we just didn't do a good job of letting people know, look at all this exciting science that is happening, just in case we need a vaccine.
And that successful, rapid development turned out to be a curse because people refused it because it happened so fast. So it's quite ironic. But even with the speed at which it came out, it even surprised, a lot, even in October, people were asking, when people still wanted vaccines, when is it coming? When is it coming? And I think maybe even Dr. Fauci was saying, we're, hopefully in the first quarter of 2021 is what we heard. So for it to have come out even months earlier than even what he thought, it was a great feat, but unfortunately it was misinterpreted and caused significant destruction and death.
So I'm getting the signal to start the Q&A, but I have to ask one other question. So in the title, it said that this was for the post-pandemic world. Are we post-pandemic? And if we're not, how will we know that how will we know when we are?
We'll know it when we see it, right?
Exactly.
No, I know that's the question that, the governor always gets, like, when are we going to stop wearing masks? When's the mask mandate? We've been looking at the numbers and everybody's like, I heard the numbers are going down. For 7 consecutive weeks, we had case totals, like new cases of COVID, people going into the hospital, total patients in the hospital decreasing for 7 weeks. And so we started some of those discussions. But, for me, it gave me such, so many palpitations to think of, oh, yes, the mask helped decrease transmission. Let's stop it. It's like saying, yes, the seatbelts have decreased, motor vehicle deaths by this many. Stop wearing them now. Like, it doesn't make sense to me. But there is some psychological effect, I guess, whether it's manufactured or not, but if it's something that people are perceiving that they want freedom for their faces. So, we've been trying to have these debates about, when would be the appropriate time. Of course, in the last week now, we've seen the numbers start to increase again. And so it's like, not now, not now. We really need to have, sustained decrease. But the truth is, with the ready availability of vaccines and now with expanded eligibility with our kids, it does mean that more people have the ability to fully protect themselves. And, if your vaccine immunity starts waning, get boosterized, right? And so, there's just more and more ability to protect ourselves and protect the health resource in terms of not having as many people who should end up in the hospital. But right now, we have 125 people that get admitted to the hospitals in Illinois with COVID every single day. And so with those kind of numbers, I would say we're definitely not there. I think we had set a threshold because the truth is, I don't know if it's okay to say it, but let's let them know, like, COVID's going to be with us. It's not going to be a day that we say, it's gone, it's not going to happen. It's going to be with us. And so figuring out, it's not something that people want to articulate. What's the level of people going into the hospital? What's the number of COVID deaths that we can tolerate? That's not something that you like to hear, but, we're going to have to establish those kind of thresholds so that we can pivot from some of the aggressive, top speed, COVID plans that we're doing and kind of pivot. Again, we might not be there just yet, but as we think about more people getting eligible for vaccines, as we think about more therapeutics, antivirals, where you can take medicines for 5 days, those things will help us get to the point where, yes, COVID's there, but it's not going to be the front line, the only thing that we talk about every day, every hour.
It's, I agree with you. It's, I stayed up really late last night watching my team win the World Series. So I'll use a baseball analogy. We're in the 7th inning. We're doing well, but it's not over, okay? It's not over until it's over. And we're not there yet. Things are looking good, but you still have a ways to go. And for 2 reasons. Number one is there's still a global pandemic. And we cannot forget that pandemics are global. And globally, about 500,000 people are being diagnosed and about 7,000 people are dying every day. And as long as there's a global pandemic, there'll be the emergence of new variants in other places. So when people say, when will this be over? Well, the sooner we vaccinate the world, the sooner it will be over. So everybody in this country needs to write to their Congress and say, it is important for the US to assume a leadership role because it's in our best interest to end the global pandemic. It's an issue of national security, but it's an issue of national interest. The sooner we end this globally, the better it is for us. And I think that's a very important message that needs to get across, is that we can end it here, but if we end it here and we don't end it globally, we haven't ended anything. The second thing is that I think the future of COVID is it's going to be more of a chronic condition. It's going to become endemic. And what we're going to see is little outbreaks here and there. And I think what I tell people is, you're going to see cases. What you don't want to see is outbreaks, and what you don't want to see is huge outbreaks, and what you don't want to see is an increase in hospitalizations, an increase in deaths. And yes, we need to ask ourselves, what is the number of deaths that is tolerable? To me, it's frankly intolerable that we have 1,500 deaths per day, and people are sort of numb. It's like nothing is happening. And I'm like, excuse me, but that's a lot of people. I think, the flu normally kills 35 to 40,000 people a year. So that's about 100 people a day. So I think if we get the number of deaths below 100 a day as a nation, it will be a good place. I think we can get deaths down to 100. And then hospitalizations is the other thing. You want to prevent hospitalizations, not only because of COVID hospitalizations, but because of COVID hospitalizations displaced other patients. And therefore mortality from other diseases goes up. So, several people have thought about this. And I think if you bring COVID hospitalizations down to less than 5 per 100,000 population, it's probably a reasonable place to be. But we need to come, and one of the things that I've been pressing Dr. Walensky and CDC is to come up with those metrics, because the reality is if you don't come up with those metrics, if you don't publish that, then people keep on asking, what is the end point, right? What is the goal point? And again, one of the bad things that we can do in public health is tell people, let's keep on moving the goalpost. That doesn't help. At some point in time, people want to say, if this happens, you can do the following. And this question comes up all the time now. People frequently say, the other day I was talking to a lawyer's office, and they said, 100% of our office is vaccinated. Do we still need to continue wearing masks? It's a very good question. And the answer is probably not. The question is, how much risk are you willing to tolerate? Is one of those lawyers a transplant recipient or immunosuppressed patient, or they're all young people? I mean, there's a lot of ifs, right? But at some point in time, we're going to have to say, what are we willing to tolerate? How much risk are we willing to take? And exactly like seatbelts, we all, on a daily basis, take risk. I put my seatbelt, but I say, I get on the freeway and I'm, driving 70 miles an hour. That's probably not very safe. If I really want to decrease my risk, I probably wouldn't get on my car to start with. So at some point in time, you need to make a decision of what is a tolerable risk. And people and families, Thanksgiving is coming up. The holidays are coming up. And questions come up all the time. Well, should we get together? Who can come? Who cannot come? Should we do testing? What do we do? I think it'd be nice if we can sort of outline it for people and say, look, the following, if you want to decrease, it's not going to be zero risk, but these are the things you can do to decrease the risk. I guess it's no different than cooking Thanksgiving dinner, right? There's some things you would do to the turkey that probably will increase your risk of infections. There are other things so you cook it to a certain degree because you want to decrease the risk, right? Well, it'd be nice to come up with a certain list of things saying, look, if everybody's vaccinated, you can have a family gathering of people that are all vaccinated. It's okay that everybody's on mask, and you want to do it less risk, do it outdoors. It's going to be too cold, then do it indoors, but open the window. I mean, come up with some sort of recommendations, because what I think we need to do a better job in public health is not telling people what they cannot do. telling people how they can do things, telling the way to do things. Because what people don't want to hear anymore is, oh, you can't do this, you can't do that, you can't do this. At some point in time, people say, forget it, I'm going to do it. And again, that's a lesson from HIV. Telling people don't have sex doesn't work. We have learned that, okay? So a lesson from HIV is telling people don't have sex is not going to decrease HIV transmission. So we need to tell them how to decrease the risk. So risk reduction, harm reduction is a critical component of the message we need to give going forward in COVID.
And I hope you've seen that in some of the guidance that we've put out, because very early on, I was like, we can't keep preaching. We just need to encourage people, give them some tools with which they can do things safer. So, the draft might have said before it came to me, like, don't trick or treat inside of buildings. And I was like, wait a minute. First of all, there's an equity issue. Not everybody has the ability to run around in the neighborhood and go door to door. It might not be safe. And, you have to tell people, like, safer ways to do it involves being outdoors, right? Ideally, if you have to be indoors, then you will try to open as many windows as possible, try to maintain the distance, but you have to be cognizant of, like, people just hearing, no, don't do this, don't celebrate this, steal Thanksgiving from them, like, at some point people will, like, unite and rebel, even the most well-intentioned, right?
Or they'll ignore you.
Right. Yeah.
At some point in time, people say, I'm not going to listen. They stop listening. And I think we need to...
It's impractical.
We need to be practical.
Yeah. And you mentioned that getting to 100, if you got to 100 deaths, that might be something more reasonable. Just for level setting and understanding where we are in Illinois, we are at about 25 deaths reported per day in Illinois.
And I'm talking 100. I'm talking 100 in the entire country.
I know. And we are at 25 per day in Illinois alone.
Yeah, in the country, we're at 1,500 per day.
So do we have any questions from the audience? Go ahead. So we have mics set up in the front on both sides if you'd like to walk up and go ahead and ask your question.
So this is mostly for Dr. Nzike. We met once before. So during your press conferences with the governor, which I saw many of them, I was struck by the fact that there was no encouragement for you people to tell people to exercise. Let's take Chicago's population. I'm not going to talk about downstate, but there's a lot of people in Chicago, and I'm talking in the hundreds of thousands who are very unhealthy. Child and adult obesity, diabetes, heart disease, and on and on and on. And yet you guys never talked about people going for a walk or go for a jog or a bicycle ride. And if you take Gage Park, Sherman Park, Washington Park, Douglas Park, Humboldt Park, if 10,000 people had gone to those parks from those neighborhoods each day and walked a mile in those communities, you would have had a lot less COVID deaths. And there was no encouragement of that. And that should have been a national thing coming from the Surgeon General or the president. Now, we don't have to talk about the X. But anyway, I really think the governor needs to look at all the issues that surrounded COVID and realize that encouragement of exercise was missing from your message. And did that ever come up at your meetings?
No, I appreciate that. That's, of course, the management of all the chronic diseases that we saw, whether it's obesity and obesity leading to so many other things, hypertension, diabetes, et cetera. Absolutely, health promotion is really one of the important lessons of the day, that you need a healthier populace to start with, then you won't be as ravaged when whatever comes through. So I appreciate, I received that.
I lived in Miami for 15 years. And there's also, while everybody likes to look good in Miami, there's a lot of unhealthy people also in Miami. And so, you should even now be encouraging people to exercise, and that public message is not there.
Thank you very much.
Thank you so much.
Appreciate it.
Change your
Great point.
Thank you.
Point.
I was wondering if you could answer, you talked to all of us about misinformation and how quickly it came about through social media and other mediums. And I'm wondering if any of you had to receive additional training on how to be better communicators, or what ways did you find public health and communication merging or coming together to help combat misinformation?
So so I think people in public health and medicine should receive education, and they don't currently, on how to communicate to the press, to the media, to the public. And we all get trained on how to communicate scientifically, right? How to write an abstract, how to go to meetings, how to give a talk. But it's really speaking to a group like this, speaking at your local church, speaking to the media, so speaking to the general public, something that most people don't get training on. I was fortunate that when I was in charge of the National AIDS program in Mexico, I developed a lot of experience. And then in 2007, when I was in Emory, and the hospital I was working at was in severe financial crisis, and I was being asked to be at the press a lot. My dean actually sent me to media training, and that was incredibly helpful, because having CNN there was really helpful to just get trained on how to communicate and how to talk to the media. And I would say that that's a skill that is lacking in a lot of people, and a lot of people in public health and in medicine need to do a better job. And on the other hand, we have some outstanding communicators. We have some people that have done it very, very well. I think the problem is not necessarily it's training, but it's also is that ability to be able to distill very complicated facts into simple terms. And I remember, again, Denzel Washington in the movie Philadelphia, when he says, explain it to me as if I was a 5-year-old. And I always, when I'm talking to the general public, whenever I get an interview on CNN or something like that, I'm always thinking about, how do I explain this in terms that everybody can understand? How can I explain this in a way that a 13-year-old can say, I understand what you're talking about? Because we tend to doctor speak a lot. So you have to really dial it down. You really need to sort of take off your doctor's hat and speak in very simple terms. And sometimes when you speak in very simple terms, a lot of people in medicine feel like they are undervaluing their knowledge. And I think, again, you need to tell people this is not about showing off your knowledge. This is really about communicating basic, very, very complex things in very simple terms.
No, absolutely. Despite, quite a bit of money that was spent on learning medicalese, you have to be able to speak in other languages and just speak, commonese, if you will. My training for public speaking, I think, was not as formal as yours. I loved being the lay reader at church, and I think I won a poetry recitation competition. Shel Silverstein, I cannot go to school today, said little Peggy. I think that was the extent of it, but a lot of on-the-job learning. The Association of State and Territorial Health Officers is basically an organization of all the public health directors from the different states and the territories. So that's a wonderful organization. And they actually brought on Frank Luntz. Frank Luntz was the big political pundit that who would do the interviews with potential voters, and they would score like how things resonated with them. So he actually was really helpful in doing similar around COVID and trying to figure out what messages would work and what things not to say and what things don't resonate. And also breaking it down, like if you have people who are Republican leaning, never say this. So it was really dissected down, trying to explain how, different messages are needed for different groups, and what are the buzzwords and what are the words that you absolutely, want to stay away from.
It's funny that you say that, because a few times that I've gotten to speak to our governor or our governor's office, I've been told very clearly, don't say the word mandate. You can say we need to encourage people to get vaccinated, say all the different things, but there's certain words that will generate a very negative reaction. So you need to avoid them, and you need to learn how to not put them into your conversation, right?
Dr. Ziki, I think you're a saint for tolerating the anti-vaxxers. But my question is, Governor Pritzker has changed manufacturers for his new vaccine, his booster. How much messaging have you had to put out yesterday and today to counteract that?
I missed the first part. You said he's put out many.
No, he's changed the manufacturer for his booster.
Oh, he changed the vaccine.
Right. How much messaging have you had to put out?
Yeah, no, I think, he was asked at the press conference when he got the vaccination, he started with Johnson & Johnson, and then he got Pfizer. And I think he was asked, why? I mean, the CDC did approve mix and match. So, if there's a three-sided coin, you could, flip it and figure out which one you wanted to get for your booster. I think because the CDC laid it out very clearly that you can choose any of the three. I mean, I think that's it's almost a natural response. If, Pfizer did its little, if the J&J vaccine did its part, maybe I can get some added, there can be some synergy if I get, another vaccine. So I didn't get the question, I didn't get too much, concern and alarm over, oh my gosh, why did he pick that one? But I will say that when people put the argument or the thing that, oh, these vaccines are all experimental, they're under EUA, I think what has absolutely gotten lost is that the Pfizer vaccine for adults is not experimental. It has received the actual biologics license application, the full normal approval that your flu shot and the measles and tetanus shot has received. So you could say that he's getting the one that has the full approval as opposed to the emergency use authorization, which some people are trying to react to.
Yeah, I would say you're absolutely right. First of all, it's the only one that has to receive a BLA. Number two, I think I would say the governor is following the science, right? The science says that it doesn't really matter. But the third thing is also an issue of logistics. I don't know what your situation is here, but I can bet you that Johnson & Johnson right now is really hard to find, but Pfizer is plentiful.
That is true. But,
so
I mean, of course, we could have gotten it for the governor. Whatever he wanted, we would have gotten it.
But the reality is, from a practical standpoint, I really hope everybody chooses Pfizer because there's plenty of Pfizer. If you go and try to find a vaccine right now, what you find the most is Pfizer, then Moderna, and then Johnson & Johnson is actually pretty difficult to find nowadays because there's not a lot of demand for it. So if you go to CVS or any places, you'll see that what's plentiful is Pfizer. So it's also an issue of what's available. And that's what I tell people, rather than spending hours trying to locate the vaccine you want, if you're going to get a booster or you're going to get your first shot, just get the vaccine that is most readily available. And that happens to be Pfizer right now. I mean, there's plenty of it.
You got time to be fully boosterized before Thanksgiving. So get it this week.
Yeah, I guess I was just wondering, one thing that's happening in the public health sphere right now that's giving you hope for the future, public health wise, because I know there's a lot of nothing. Okay.
No.
Very scary. So yeah, anything that's giving you hope right now.
So 2 words, Rochelle Walensky. I mean, I think she is incredibly smart. She's a very good communicator. She knows what she's doing. And she has done a very good job communicating to Congress. And she's got, again, the job of a CDC director is to manage up. You need to get Congress to open their purse and to facilitate the monies that you're going to need to hire the public health force and to do this and to do that. And she's doing that in a very effective way.
And I'm glad to see more eligibility for the vaccine. I think the more people that get vaccinated, of course, I mean, as Dr. Del Rios has already said, it's very important that we realize that the pandemic is not just what's happening in Illinois or the US. So, we really do need, I reached out to the feds early on and said, shouldn't we be, can we adopt a city? Can we adopt a city in another country and say that we're going to give vaccines there? This was when we couldn't even give $1 million away for somebody to get a vaccine. We were doing lotteries and we're doing incentives, and the vaccines were sitting, in the freezers. And so we said, can we try to adopt a city, an international city, and try to get vaccines to a place? And they were like, this is not your vaccine. You are being given this product that belongs, to the national government, and you can't use it in a way other than how we've given it to you for, so that wasn't allowed. But the truth is, I know the US is doing a lot to vaccinate. Other parts of the world is probably the largest donor of vaccines, but we still need more. I think, 3% of the developing world is vaccinated. We've got a long, long way to go, but I think, at least as people think about, their lives here, we're trying to do all that we can to get as many people vaccinated as possible so that we can prepare for whatever the next variant is. So people are saying, well, the Delta variant is going down. It's like, Yes, but I don't know Omega or Zeta, like what's the next variant that we will see. So you need to be ready for that, right? You need to be ready. With I think it's Snoop Dogg. If you stay ready, you ain't got to get ready. So you get vaccinated now and get all the protection in advance of whatever might be around the bend.
So I guess I'd like to ask about our healthcare workers. We celebrated their heroism, particularly at the beginning of the pandemic. They continue to be drawn upon, asked to do more, asked to work longer hours. And we're experiencing a continued and exacerbated epidemic of mental illness, mental health challenges for our pharmacists, our nurses, our physicians, people leaving the profession, shortages across the board. What's the role of public health in supporting these professions and for making things better for those who want to pursue a lifetime of caring for others?
I want to give everybody a year of vacation because they need it. No, the reality is that you're absolutely right. It's a very serious problem, and people are tired. People are very tired, and also people are leaving. I think throughout the country, you have a crisis of a shortage of nurses, of respiratory therapists, of multiple people. I mean, if I give my hospital money right now, they can't hire the nurses that they need because simply they're not out there. So I think there is it's not an easy answer. I would say the first thing we need to do, and I was talking about this today in a call with leadership, is we need to continue telling people thank you. One of the things that I do on a daily basis in my hospital, just go around and go tell everybody, thank you. We know you're here. We appreciate you. What are your concerns? I think one of the biggest challenges that people have right now in healthcare, and something that we have to do better, is in order for you to go to work, if you have young children, is to be able to get your young children go to school, right? A school opening is critically important for the economy to function. It's not just about educating kids, it's allowing parents to do what they need to do. And when schools are so somebody was telling me, well, my kid, I can't go to work today because we just got a call from the school saying that somebody was diagnosed with COVID and therefore everybody has to be in quarantine at the school. Well, it is ridiculous. We in public health are making a problem because by quarantining everybody, we're essentially sending all those kids home. So I was talking to people at my university saying, shouldn't we set up a quarantine daycare where those healthcare workers can actually drop their kids and say, look, my kid is quarantined from school, but here's the sort of school daycare for quarantine. We need to figure out a way to help those healthcare workers who currently are having to take days off to stay home with kids who are being sent out from school. Hopefully this is going to get better with vaccination of kids. But I can tell you in my state, we're not going to see, mandatory vaccination of kids. So this may continue to be an issue that happens. Number two, I think we need to give people time off. We need to figure out a way to not demand more and more from people. And number three, I think we need to really provide on-site, help. And the on-site help is all sorts of things. It's, for example, I am hiring for our hospital, 4 psychologists to be there available 24/7 because, to telling an ICU resident, well, I know you had a very tough mental health time. Go make an appointment with a mental health provider and, waste a day doing that, which is on your day off. It's not going to work. We need to have it right here available to you, that if you need that resource is right here. And that needs to be a service that we provide to our healthcare workers in the health system, available at the time that, if somebody's working in the ER 12 midnight to 7 in the morning, and they want to see a mental health provider, they can do it at 8 in the morning or at 10 o'clock at night before they go to work, and not at the time that is convenient to the health. So I think we need to make those investments in order to make those resources available on site for people to feel supported.
Yeah, we've done some of that. The airplane analogy, put your own face mask on before you try to help anyone else. So, I did secure a team of mental health specialists to work with the public health team, the COVID response team, the people who've been doing this, we started this about 5 months ago, brought a team on to help the COVID response team, who's really been doing this 7 days a week, for that almost the 15 months probably then. And then we expanded the service and made it available to the local health department leads who've been enduring as much, if not more than. And so as we're trying to deal with issues ourselves, we're now looking at the Illinois Health and Hospitals Association and trying to see, this is the organization that, oversees like the 200 plus hospitals, trying to engage in those conversations to say, what are we going to do for the healthcare, for the clinicians, for the healthcare workers who have been embattled. The Department of Human Services, they have a lot of work in that mental health space. They've created a text line that anyone who wants to get some mental health supports just via text, if you, I think it's, I don't want to say the wrong number because I don't know where you'll be sending your information to, but there's a text line that you can see on the DHS website that, you can send your number, text to this line, and you will get, at regular intervals, I don't know if it's every other day or weekly, just get some encouraging supports. It will give information of where you can, read up on other information. But we definitely do need like a statewide plan. Like we all need to heal. Probably maybe it needs to be at a federal level where we think of what does that program look like to have, national period of healing, acknowledging that all of us in some form or other, are enduring, PTCD, post-traumatic COVID disorder. And even though it's ongoing, that's even worse that the trauma is ongoing and so prolonged. So we definitely do need some better strategies. We definitely all need to be seeking that mental health support. We do need to make it readily available for the people who need it. And that's going to be part of a long process of healing to deal with all the traumas we've faced, whether caring for people versus the people that we've lost or watched leave or et cetera.
I've called it flattening the emotional distress curve. Just like, remember in the early epidemic, we said, when you're doing this to flatten the curve, I said, well, we need to do these things to flatten the emotional distress curve. It's part of our intervention.
And let's go ahead and wrap up with a final question.
Yeah, so this is just not a question. I just personally want to thank Dr. Isike for all the work that you do. And then just like on a personal note, especially last year when everything was happening, all the press conferences, I specifically used your videos that you would talk in Spanish, and it just how much it meant for me to be able to share with my family and my community information that they could understand, because there was so much misinformation, and you kind of became like the voice of reason of like, I'm not panicking because I'm listening to her and she has like information that we need right now. So you saved a lot of lives.
Thank you
I
so
just want to personally thank you for that.
Thank you so much.
All right. Thank you, everybody, for being with us tonight, and thank you to our panel. So.